Thanks very much, Dr. Kloner, and like the other speakers, I'd like to thank the organizers for this. Because it's getting very late and I'm what's separating you from either bed or the bar, I'm going to be very brief. So I have no disclosures that are pertinent to this talk. So there are a number of ways to measure endothelial function. I'm just going to show you a couple. You heard already from Greg about PAT in terms of how that works. Flow-mediated dilatation has been around for now 20 years. Basically, you take a linear array, high-resolution ultrasound probe, and you measure the brachial or the radial artery. You then apply a 5-minute ischemic stimulus to the forearm or the upper arm, and that's important because when we talk later, it'll be a 15 or 20-minute occlusion that leads to the ischemia-Reperfusion. And when you do that, you then measure the diameter of the artery, and anywhere between 45 and 90 seconds afterwards, the artery dilates. And with quantitative techniques, with analysis software, you can measure that flow-mediated dilatation. This is mainly nitric oxide dependent. About 80% of the response can be blocked by nitric oxide. And we used to think that was the best way to measure endothelial function. About 4 or 5 years ago, people began to think about the stimulus, the increase in flow or shear stress that occurs as a result of inflating the cuff and then letting it down. And what we know is that that increase in reactive hyperemic velocity or flow is only partially nitric oxide dependent and is dependent upon things that act in the microcirculation like adenosine, ATP, potassium channels, endothelial-derived hyperpolarizing factors, etc. And there's lots of literature to suggest that maybe the stimulus or the microvascular response is as important. Now, these are classic articles that you've alluded to back when Dr. Kloner was probably in grade 6. He published this pivotal study of no reflow in dogs. That's important because as an interventional cardiologist who spent a lot of time in the middle of the night doing primary PCI angioplasty, this no reflow phenomenon that occurred with ischemia-reperfusion indicated to us that there was abnormalities in the vasculature and vasomotion. And you heard about the other classical studies that have occurred. And really, it's the ischemia conditioning study by Murray, Reimer, and Jennings, which is one of the most cited circulation papers in history that really set the stage for this area. Both preconditioning and post-conditioning, as you've heard from mechanisms, share very similar kind of triggers, mediators, and end effectors. And what you can see on this review from the Vinton-Johansen group is that both protected effects and abnormal effects on the endothelium are important. So when this field started, they weren't really thinking about the endothelium. It was really more about left ventricular dysfunction and the size of the infarction. But what became very clear in a number of different models, which I won't have time to go into, but basically in isolated arterioles or in animal models, is that ischemia-reperfusion resulted in damage to the endothelium that led to endothelial dysfunction. So if we summarize this, and we'll just go through 2 or 3 studies, is that ischemia-reperfusion injury causes acute conduit and nitric oxide dependent microvascular endothelial dysfunction, and I'll show you pivotal studies around that. Pre and post conditioning with ischemic preconditioning bouts of transient ischemia can attenuate this abnormality. So there's a nice human model of acute endothelial dysfunction that's really useful for studying mechanisms, but also for studying different interventions. Pharmacological conditioning, I'm just going to touch on that as well because that's important as we look at mechanisms and also different therapies, and remote ischemic preconditioning you've heard about. So this is the first study. So Karabanda and group had done animal studies, but this is their first human study published now 12 years or so ago. And basically what they did is they measured endothelial function here at baseline. They then applied ischemia and reperfusion and then measured at 15, 30, and 60 minutes. And then they repeated the studies again with a bout of ischemic preconditioning where they measured baseline endothelial function, 5 minutes on, off, and then did the ischemia-reperfusion and measured endothelial function later on. And what they showed was several things. So firstly is that they studied microvascular endothelial function by infusing acetylcholine into the forearm and using impedance plethysmography. So what they found was that here in responses to increasing doses of acetylcholine is that prior to the ischemia-reperfusion is that there was a dose-dependent increase in this blood flow. And this is a nitric oxide dependent pathway. Dr. Kiyumi and his colleagues at the NIH wrote hundreds of papers, maybe not hundreds, but teens of papers around this. But what you saw is that after 15 minutes of ischemia-reperfusion is that there was a marked decrease in this microvascular response to an acetylcholine stimulus. And this occurred at 15, 30, and 60 minutes. With the non-invasive technique, though, what they showed is that there was a very marked decrease in flow-mediated dilatation with this ischemia-reperfusion model, and that this could be completely attenuated by ischemic preconditioning. So if you did the preconditioning, is that this block or this decrease in flow-mediated dilatation did not occur. And this became a model where people could look at acute endothelial injury and then look at different ways to improve that. They followed that up a year later with a remote study where they used the contralateral arm and again showed that endothelial dysfunction in the microvasculature by looking at the change in blood flow to acetylcholine was attenuated, but if there was remote ischemic preconditioning, is that there was not this abnormality in the microvascular response. Similar, same group, now a number of years later, and what they then looked at was a variety of different things. One, how much remote conditioning did you need? Did it matter if it was on the arm or the leg? How many cycles did you need? And was this dependent on a potassium ATPase channel? So a complicated group of experiments, 135 experiments, 19 healthy subjects, remote ischemic preconditioning, and now remote post-conditioning, where the conditioning stimulus was applied at the time of the ischemia. And basically what they found is that both preconditioning and post-conditioning had beneficial effect. It seemed that the preconditioning was probably better. Here's the flow-mediated dilatation. You see the decrease here down to about 3 or 4%. Is that if you had 2 cycles on the arm, not statistically better. If you had 2 cycles on the leg or 3 cycles on the arm or the leg, is that you could attenuate that decrease in endothelial function. So it seems that the volume of ischemic tissue is important, and then they could block this completely by giving glibenclamide or gliburide, which is a potassium ATPase channel, getting somewhat at mechanisms. We did one study in this domain that we just published in the last few months. My interest was in PAT to see if ischemia-reperfusion attenuated the PAT signal. And so what we did is we took 45 healthy subjects with 15 minutes of ischemia and looked at flow-mediated dilatation, the hyperemic stimulus, and also the PAT index. And what we found is that flow-mediated dilatation decreased from 8% down to 4%, but there was no attenuation of PAT index and there was no attenuation of the VTI or the hyperemic stimulus. So the microvasculature was intact, but the conduit vessel response was attenuated with 15 minutes of ischemia. So if you look at studies down the road, you have to pick the right endpoint that you want to use. Pharmacological conditioning, just a minute on this. John Parker in Toronto and his group have published a number of studies on this. Basically the exact same mechanism with the ischemia-reperfusion injury and flow-mediated dilatation, and they've shown a number of acute interventions are able to attenuate that response, including statins, and you would think that statins would do it by nitric oxide dependent pathway, but in fact it's a COX-2 dependent pathway. They've shown it for some kinds of nitroglycerin, they've shown it for sildenafil, they have not been able to show it for folic acid and a variety of other things. Interestingly, acute intervention works, but if you do it for a longer period of time, most of the beneficial effect goes away. So if you give 1 dose of statin, you can ameliorate the decrease in flow-mediated dilatation. If you give a week of statin, then you see no response at all. So very interesting in that domain. What they were able to do, though, is published in the Journal of the American Heart Association in the last few months, is that they said, well, chronic interventions don't seem to be working. What about chronic ischemia-reperfusion? And this is really very pertinent for this. And so they took 30 healthy subjects and they did the ischemia-reperfusion protocol with and without celecoxib as a COX-2 inhibitor. They did this also with a 1-day protocol of ischemic preconditioning, and then they did a 7-day protocol with ischemic preconditioning as well, and they measured endothelial function before and after all of these. And what they were able to show in here is that, as you would expect by the other studies, is that flow-mediated dilatation decreased dramatically without any conditioning stimulus, and that this was not affected by inhibiting COX-2. is that with 1 day of ischemic preconditioning, as other people have shown, is that there was less attenuation, and this was not blocked by the COX-2 inhibitor, but for the first time showing that a 7-day, once-a-day ischemic preconditioning is that endothelial function was absolutely maintained, and that this was not COX-2 dependent. So this is the only study I think that I've seen that's shown this, and this is at least what they report in the last 3 months or so, and quote, no other literature, and I could find none in PubMed. Okay, so in conclusion then is that this is a nice model looking at endothelial function in humans, is that acute or repeated episodes of ischemic preconditioning can improve this attenuation. But what's not clear is if you take individuals with endothelial dysfunction, because all of these studies have been done in normal people. So if you take somebody that has a significant endothelial dysfunction, will this still hold? And there's an opportunity for research. What's also not clear is whether this will affect baseline endothelial function, or does it just affect that decrease in endothelial function that you see with the ischemia-reperfusion, and what is the relationship then in the long term? Acute in 7 days of ischemic precondition can ameliorate the ischemia-reperfusion-induced decreases in FMD in the conduit vessel, but doesn't seem to affect the signal for it. The preconditioning may be more effective than post-conditioning in this model, although that remains to be seen, and I think further studies are needed to assess the effect of longer-term ischemic preconditioning on endothelial function and other measures of cardiovascular physiology. Thank you very much.